Okay, so I want you to picture a scenario. It feels like something out of a thriller, but it's happening in a hospital room right now. You're there with a loved one. She's 75. And the big headline is that she's tested positive for COVID-19.
Right. And all the fear is on the virus.
Exactly. But we've got this whole stack of sources here. Clinical guides, pharma data sheets, and they're all suggesting the virus. It might not be the thing that kills her.
It's a terrifying thought, but the data is very clear. In geriatric medicine, the cure can very quickly become a second disease.
A second disease.
We're just looking at a viral infection here. We're looking at a collision between a fragile, aging body and, well, a medical system that's aggressively trying to treat symptoms without seeing the whole person.
Polypharmacy. That's really the core theme of this deep dive, isn't it?
It is.
So, the case study we're unpacking. She's a 75-year-old woman. She's COVID positive, and she's suffering from what the reports call excessive diarrhea and maybe even silent pneumonia.
A perfect storm.
And our mission today is very specific. We're not just analyzing the problem. We want to build a doctor discussion guide.
Yes. We want to equip you to be a senior medical advocate. Because when you're in that room or you're on the phone with a doctor who has, 40 other patients, you need the specific language to stop the autopilot, to just force a moment of clinical reason.
Okay, so let's get right into it. The immediate crisis in this case isn't the cough, it's the diarrhea.
Right.
Now, for a healthy 30-year-old, diarrhea is, it's a miserable inconvenience. You take a day off, drink some water, you're fine. But the literature you sent me treats this like a fire alarm fire for someone who's 75. Why is it so different?
It all comes down to something we call physiological reserve.
Okay.
As we age, our total body water content it drops. A younger person is like a fully saturated sponge. They have a buffer.
Got it.
An older person is more like a dry sponge. So when you get this severe high-volume diarrhea, they're not just losing fluid, they are dumping electrolytes, potassium, sodium at a rate the aging kidney just can't handle.
So it's not just the stomach bug, it's a full-on systemic crash.
It's a rapid slide. The sources are really clear that dehydration in this age group triggers a domino effect.
It's a domino effect.
First, blood volume drops, so blood pressure plummets. That creates a huge fall risk. One dizzy spell on the way to the bathroom and you're looking at a broken hip.
Right.
Then the kidneys start to struggle and you get acute kidney injury. And then finally, you hit delirium.
That's the part that really stood out to me, the doom loop. The patient gets confused because their electrolytes are off, so they forget to drink or refuse to drink, and the dehydration just gets faster and faster.
Precisely. The dehydration can act much faster and be more lethal than the virus itself. So we have to look at why it's happening. We've got the patient's medication list right here. Let's do some detective work.
Find the culprit in the medicine cabinet.
Exactly.
Okay, let's look at the stack. Suspect number 1 is the antibiotic, amoxiclav. It's a combination of amoxicillin and clavulanate. Yep, it's a standard heavy hitter. But you've zeroed in on the problem.
The clavulanate component, the pharmacology notes say that's the issue.
It is notorious in geriatric care. The data shows clavulanate acts as a gut stimulant. It physically speeds up peristalsis.
Peristalsis, those are the muscle contractions in the intestines, right?
Yes. So it's literally putting the digestive tract on fast forward.
Wow.
And the stats show up to 34% of patients on this drug report diarrhea. In a senior, that's a staggeringly high risk. And that's not even mentioning the risk of C. diff.
A really dangerous bacterial infection.
Right. It thrives when antibiotics wipe out the good gut bacteria. It can cause colitis, which is life-threatening all by itself.
Okay, so that's one. Then we layer on drug number 2 from the case study, fluconazole, an antifungal.
Which also lists GI upset and diarrhea as a primary side effect. So we have an antibiotic speeding up the gut and an antifungal irritating the lining. You're attacking from 2 angles.
Exactly.
And we still haven't even mentioned the antiviral yet. Paxlovid. I've seen the term Paxlovid poop on social media. It sounds like a joke.
It is not a joke. It's absolutely a documented adverse event. We'll get into Paxlovid's other dangers later, but just from a GI standpoint, it adds a huge load to the system.
So that's 3 drugs, all pushing the patient towards dehydration. But here's the one that really shocked me. The smoking gun. This 4th drug on the list, Reglan. Generic is metoclopramide.
Yes.
My understanding is that Reglan is for nausea. It's supposed to help you keep food down. Yeah. So why is this a problem?
And this is where advocacy really, really matters. You have to look at the mechanism of action. Reglan is a prokinetic agent.
Prokinetic, meaning?
Its job is to force the stomach to empty faster, to push everything into the intestines.
Wait a minute. If she already has excessive diarrhea, and we give her a drug that pushes things through the intestines faster,
You are pouring gasoline on the fire. You are putting a brick on the accelerator of a car that is speeding towards a cliff. By trying to treat the nausea, that prescription is actively making the fluid loss worse.
that's insane. It's the definition of a counterintuitive outcome.
And it gets worse. The sources all flag a black box warning from the FDA for Reglan in the elderly.
That's the strongest safety warning.
It is. It can cause something called tardive dyskinesia.
Because of the involuntary muscle movements, right? Like facial tics.
Yes, and in this age group, they can be irreversible, even after you stop the drug. So you have a drug worsening the dehydration and risking permanent neurological damage.
This brings us right to the first part of our advocate script. We promise the exact words to use. So you're in the room, the doctor's on the phone, you see this cocktail of drugs. What do you ask?
You have to be direct but collaborative, you say. Given her excessive diarrhea and the risk of kidney injury, is it strictly necessary to continue the amoxiclav and the Reglan? Specifically, can we pause the Reglan immediately?
I love that phrase, strictly necessary. It forces a pause.
Yeah.
Shifts the whole conversation from standard protocol to clinical reasoning.
That is the entire key. You're not saying, I know better than you. You're saying, the context has changed. The diarrhea is now the primary threat. Do these meds still make sense? You're helping the doctor step outside the algorithm.
Okay, let's pivot to the lungs. The case study mentions silent pneumonia in this antibiotic trap. We just talked about amoxiclav causing diarrhea, but if she has pneumonia, don't we need the antibiotic? Isn't that just standard care?
This is such a huge misconception, and it's where a lot of people get trapped. COVID-19 causes viral pneumonia. Amoxiclav treats bacterial pneumonia.
So it's the wrong tool for the job.
It's like trying to fix a software bug with a hammer.
And it's not a harmless attempt?
No, it's not a neutral act. As we said, the antibiotic destroys the gut microbiome. So for a viral pneumonia, you get zero benefit for the lungs, but you take on all the risk for the gut. You're actively harming the patient just in case.
But couldn't she have both? With a 75-year-old, is there a chance of a secondary bacterial infection on top of the COVID?
There is, yes. Bacterial superinfection can happen, but you should not guess. The advocate's script here is all about demanding diagnostics before you treat. We call it proof before poison.
Proof before poison. I like that. So what's the proof we should ask for?
Two things. First, a chest x-ray. You want to distinguish between the patchy grand glass look of viral COVID and the dense consolidation that suggests bacteria.
If it's just ground glass.
The antibiotic is likely unnecessary and harmful.
Okay, what's the second diagnostic?
Pulse oximetry. And this connects to silent hypoxia or happy hypoxia.
Oh, right. This was a really bizarre feature of COVID.
Baffling, especially in seniors. Their oxygen saturation would drop to dangerous levels like the low 80s, but they wouldn't feel short of breath. They wouldn't gasp or panic.
I found that fascinating. Usually if I hold my breath, my brain is screaming at me. Why does that happen here?
Well, the brain's alarm system is mostly triggered by rising carbon dioxide, not falling oxygen. And with some COVID cases, the lungs are still getting rid of CO2 just fine, so the alarm doesn't ring.
The patient just feels tired.
Or a little confused. Meanwhile, their organs are starving for oxygen, so the grandmother sitting quietly in the chair could actually be in respiratory failure.
So you need to check her oxygen, not just at rest.
But after a short walk, if it's safe, you need to see if the demand of walking to the bathroom causes a crash.
Okay, so the script for the doctor about the lungs is,
Can we confirm she has bacterial pneumonia via x-ray before continuing antibiotics that are worsening her dehydration?
Yeah.
You're shifting the burden of proof. You're asking them to justify the risk.
okay, let's move to offense. We've been playing defense against side effects. But we do need to stop the virus. She's high risk. We need an antiviral. Now, we mentioned Paxlovid and diarrhea, but the sources point to a much darker problem with Paxlovid in this age group.
This is the antiviral puzzle. Paxlovid is incredibly effective at stopping the virus, but the way it works is tricky. It shuts down a specific enzyme in the liver called CYP3A4.
CYP3A4, I was reading about this. It's basically the liver's garbage disposal system for drugs, right?
That's a perfect analogy. It clears a huge percentage of modern medications. Paxlovid intentionally jams that garbage disposal so its own active ingredient stays in the body longer. The problem is, it also jams the disposal for dozens of other drugs.
And a 75-year-old is probably on a lot of other drugs. Statins, blood thinners.
Exactly. So those drugs suddenly have nowhere to go. They build up rapidly.
What happens then?
If she's on a blood thinner like rivaroxaban, her blood could become dangerously thin. You risk a massive internal hemorrhage. If she's on a heart med like amiodarone, she could have a fatal arrhythmia.
So you treat the COVID, but you cause a stroke or heart failure. It's a minefield.
Correct. Which brings us to the script. You have to ask, if we use Paxlovid, have we cross-referenced all her maintenance medications? And honestly, with the diarrhea risk, Paxlovid might be a bad call for her anyway.
So what's the alternative? If Paxlovid is too risky, are we just out of options?
Not at all. The sources highlight remdesivir. It's an IV infusion, usually given over 3 consecutive days.
And why is that safer here?
2 big reasons. First, it bypasses the gut completely, straight into the vein, so you avoid the Paxlovid poop. Second, it doesn't have that CYP3A4 interaction. It plays much nicer with other drugs.
But it requires infusion. That's a logistical challenge.
It is, but think about it. For a dehydrated senior, getting hooked up to an IV is actually a bonus. They get fluids right along with the medicine. Kills 2 birds with 1 stone.
And if IV isn't an option, maybe they're in a rural area or something?
There is molnupiravir. It's a pill. It's statistically less effective than Paxlovid, but it doesn't have the interaction baggage. It's a valid plan C.
So the advocate asks, is she eligible for a 5E remdesivir to spare her gut and avoid these interactions?
Exactly. You fit the treatment to the patient, not the patient to the protocol.
Okay. We've navigated the medical strategy. We've had the tough conversation with the doctor. Now we're back home where the caregivers. It's 2 a.m. The diarrhea is still active. What's the home survival strategy?
This is where the rubber meets the road. The most common mistake, and it's always done out of love, is thinking, she's dehydrated, give her lots of water.
Which sounds completely logical.
It sounds logical, but biologically it can fail. When you have diarrhea, the gut lining is inflamed. It loses its ability to absorb plain water efficiently.
So the water just goes right through her.
Or worse, it can actually flush out more electrolytes, leading to low blood sodium. That can cause seizures.
Wow. So water alone is useless.
In severe cases, yes. You need what's called the sodium-glucose co-transport mechanism. Basically, the gut needs a little bit of sugar and salt together to unlock the cell and let the water in.
Which is why we use things like Pedialyte or oral rehydration solutions.
Exactly. Or bone broth, coconut water. You need those electrolytes. And the technique matters just as much as what's in the glass.
The sipping strategy. I love this detail.
It is crucial. If you hand her a 12-ounce Gatorade and she shoves it, you trigger the gastrocolic reflex. The stomach expands, signals the colon to empty, and boom, more diarrhea. You're right back where you started.
So you need a slow drip.
2 to 4 ounces every 15 minutes. Relentless. You're basically mimicking an IV drip, but orally. You want absorption, not throughput.
What about food? The old wisdom was always the brat diet. Bananas, rice, applesauce, toast. Is that still the gold standard?
It's a safe place to start, but the sources argue for an expanded bland diet. The brat diet is almost entirely carbs. A senior fighting a virus needs amino acids. They need protein to maintain their immune function and muscle mass.
So we're upgrading from just toast.
Add soft proteins. Scrambled eggs are perfect. Boiled chicken, soft tofu. You want to avoid the triggers like dairy, grease, or anything too fibrous like a salad. A raw salad is like sandpaper to an inflamed gut.
Got it. Now, as a caregiver, how do I know if I'm winning this battle at home? I can't run a blood test in my kitchen.
You have 2 low-tech tools that are surprisingly accurate. First, the urine test.
Okay.
You are aiming for pale yellow. If it looks like apple juice, or worse, dark amber, she is clinically dehydrated. Dark amber means danger.
And the second tool.
The log. You have to write it down. Fluid in versus fluid out. It sounds tedious, but when you call the doctor saying she drank a lot, it's useless information.
It's too subjective.
Right, but saying she drank 40 ounces of Pedialyte, but she had 6 watery stools and hasn't urinated in 8 hours? That is actionable data that tells the doctor exactly what's happening.
That's the difference between a wait and see and a go to the ER.
Absolutely. It empowers the doctor to make the right call.
Speaking of the ER, let's wrap with the red flags. When do we stop all of this and just call 911?
The sources are very clear on the non-negotiables. First, confusion. If she doesn't know where she is or who you are, her brain is either starved for oxygen or her sodium is critically low. That's an immediate emergency.
Brain checking out, call 911. Got it.
Second, inability to stand. If she's too weak to get from the bed to a chair. Is late-stage oxygen starvation.
And on the pulse oximeter, what's the number?
Anything consistently below 90, maybe 92%. And finally, the kidney signal. No urination for 8 hours. That means the kidneys are shutting down. You do not manage these at home.
This has been a heavy deep dive, but a really important one. If we boil all this down, what's the one core philosophy our listener needs to have?
It's the concept of deprescribing. Our medical culture is built on adding things. You have a symptom, here's a pill. Oh, you have a side effect from that pill, here's another pill.
Prescribing cascade.
Exactly. We treat the side effects of drugs with more drugs. The senior medical advocate has to be the one to stop that conveyor belt. You have to be the one to ask, what can we remove?
So it's a minimalist approach to crisis management.
It is. When the body is already under attack from a virus, sometimes the best thing you can do is just clear the deck. Reduce the chemical burden. Let the body do its job without fighting 3 different drugs in the gut.
So the 3 magic words aren't prescribe me something. They're, is this necessary?
Is this strictly necessary? If you ask that question, you change the entire trajectory of care. You force the system to see the person, not just the pathology.
I want to leave everyone with that thought. In a world of more is better, sometimes the most life-saving move you can make is to do less. Thank you for diving deep with us today.
Stay curious.
And stay safe. We'll see you on the next deep dive.